They're recording it, Ram, so better use a mic.
Okay.
Yeah.
So one of the shortest probably talks, short and sweet talk on iron metabolism. So this all of us know the predominant cause as per the literature is erythropoietin deficiency. The iron deficiency is quoted as the second common cause, but in our part of the world it may be really different. The iron deficiency can be functional or absolute. This was the older terminologies that have been used. The absolute can be due to blood loss due to various sources, as the functional impairment is due to the problem in iron metabolism in CKD, that inflammatory milieu. So this was the previous description. Now the KDIGO guideline have reframed from absolute iron deficiency to systemic iron deficiency, from functional iron deficiency to iron restricted erythropoiesis. So the first one, every number is low, so it's very clear. The second one, there is a disparity in numbers. There can be the third scenario also, which they have not gone into. Here they have described low TSAT despite normal or high ferritin. Generally the iron is trapped within the reticuloendothelial system and it's not available for erythropoiesis. So this is the description that is used. So this is the explanation that has been given. In systemic iron deficiency. The hepcidin is usually very low. It is not normal even in normal population. In iron restricted erythropoiesis, the hepcidin is quite high. That acts on ferropoietin, reduces iron extrusion from the reticuloendothelial system. So that is how the mechanism of iron restricted erythropoiesis sets in. This is, I am just setting the context why the role of HFPHI is important. See, there are some preclinical data to say that HFPSIs improve iron availability. They do increase the absorption of iron from the duodenum. They do mobilize the iron from the reticuloendothelial system. And the only, in a way, we worry about HIF is the number of genes the HIF activation acts on. So I will be showing some of the slides. There is n number even in the reticuloendothelial system. But what has been documented is it does reduce serum hepcidin. It increases iron and TABC both. I will show you some evidence also for that. So this is just a case. We are supposed to present a case, that's why I have put in. So this is about a farmer living in a remote zone with diabetic kidney disease, which is typical with progression over a period of 3 years, presenting with proliferative retinopathy, albuminuria, who is having edema, oliguria and so on. First hemoglobin is 8.8, 3.2 is his creatinine, and his ACR, EGFR conforms within the CKD G4A3. He did not have obvious source of blood loss. He has been on iron supplements for quite some time, but he continued to have anemia. You can see the hovering of hemoglobin levels between 8.5 to 9.2. The basic workup shows a reasonably high ferritin of 620 and TSAT around 18.1. Peripheral smear showing normocytic normochromic anemia. So this pattern is typical of iron restricted erythropoiesis. And we do have some measurement of CRP in this patient, which is quite high, though it cannot be attributed, as Sir pointed out, to purely uremia per se. So this patient is started on oral desidustat, and he was supposed to report if symptoms worsen after 3 months. 3 months follow-up, you can see there is reasonable improvement in hemoglobin, and there is fall in ferritin, and the TSAT is almost maintained, and there is some drop in CRP. This is just to give you how it works. So what we normally see when you start on desidustat is increasing hemoglobin, increasing serum iron TABC, so the TSAT remains the same. So the proportion of rise of serum iron and TABC remains the same, so the TSAT remains the same, but ferritin comes down and inflammatory markers comes down. They have actually put hepcidin. I don't think I have actually looked into our own biochemists. They said around 20,000 will come for measurement of hepcidin. So I thought it would be too much to put this into it. So that's the fact. Okay, so some basic discussion about the role of HIPHI in this scenario. So what we know is there is a quite a bit of subset of our own population who have iron restricted erythropoiesis. We see in our day-to-day life, not everybody responds to increasing dose of ESAs, increasing dose of iron. There will be a subset certainly have this iron restricted erythropoiesis. You see, the problem why it doesn't work is because they do not have any role in the iron metabolism. The disordered iron metabolism of CKD uremia is not getting corrected, whereas HF PHIs have certain roles where they do correct some of the changes in iron metabolism. And the additional advantage of this particular molecules is they can reduce the adverse effects of iron therapy, although it is little far-fetched. Okay, so this is some basic workup on how these drugs act. I think some of you might have shown this. In general, HIF alpha beta acts as a dimer. So when you have a PHT, it cleaves the HIF alpha, so there is a automatic degradation. But when it is not cleaved, it combines and go inside the cell, forms a dimer, heterodimer with alpha beta, and causes upregulation of so many genes, erythropoietic gene, and so many numbers. VEGF is one thing, that's why we worry about retinopathy in these patients. Ferropoietin is one thing, which is the beneficial part of the entire thing. So this is what I have spoken about earlier about the number of genes that gets upregulated inside the erythropoiesis metabolism itself. If you look at this, we start from the enterocyte. It causes upregulation of this. It causes upregulation. This is dimetal cation transporter that transports the iron. Then it increases ferropoietin. So that increases the extrusion of iron from inside to the outside the cell. But this is blocked by hepcidin. But you look at not only here as the site of action of this molecule, you can see this has an effect on the erythroblast itself. See, in the erythroblast, it causes increased erythropoiesis response element and erythroferron gene also. Similarly, it has effect on the liver to reduce hepcidin. There is a molecule called hepcidin antimicrobial peptide that cleaves hepcidin. So there is n number of genes that get activated with this molecule. That's why we are little scared to use it, but as we use this more and more, the confidence comes back. So this is the published data on the various molecules and their effect on iron metabolism. You can clearly see our own molecule alone will take it. See, this is the data from the D and DREAM ND studies. You can see the iron, there is no change. Ferritin comes down. There is no data on TSAT. TSAT almost remains the same. But if you look at overall most of the molecules, whatever I have spoken about is there. It does increase iron, it does increase transferrin, and it keeps the TSAT the same. Whereas the hepcidin uniformly comes down in all molecules. So that is the published data. So that's evidence enough. So I will go through some of the 1 or 2 studies alone just to show you how it works. There is evidence. That's why you can see this is the use of roxadustat, that is the phase 3 study. You can see in this roxadustat versus placebo, what happens to the hepcidin. It starts dropping as little as 4 weeks. That's why we expect the response within 4 weeks time. You can see that it sustains till the end of the study. Similarly, the same ferritin, you can see the ferritin drops from 4 weeks and kinds of keeping on and low. On the other hand, you look at what happens with iron as well as the TSAT. You can see most of the time the roxadustat increases serum iron as well as increases the TSAT. So similarly, I am not going to the details. Same data is available by the ASCENT study. So this is on daprodustat. That was an other molecule, roxadustat. So there is another interesting point they have pointed out. This is data from the roxadustat study where they looked at the time to use IV iron. So when we start on this molecule, the practice recommendation is not to start along with IV iron. Generally they say, if you want, you can start with oral iron, because you can see the time to use IV iron itself is less when you use this molecule. This is again reading between the lines. So what we have limitations as such is we don't have no primary outcome studies. And as I pointed out, different molecules use different targets. There is no uniform results. The protocols of iron depending on the study is very, very different. Certainly we need more data. So this is the summary. You can say a subset of CKD patients do have iron restricted erythropoiesis. It is typically characterized by low TSAT, high ferritin, high inflammatory markers. They have hyporesponsiveness, and this particular subgroup, certainly HIF-PHIs are effective, and this is associated with less iron requirement. In a way, you have to consider these molecules for this particular subset where you may not achieve desired result with ESAs, especially iron allergic intolerant patients who are want to avoid IV pricks. And it does avoid to a certain extent of loading people with lot of doses of IVM. Thank you so much for your attention.
Thank you, Ram. So, in which population do you think you can be seated? In which population do you think it's most useful, the dialysis population or the non-dialysis population?
Honestly, we are using more in the pre-dialysis population.
That's what everybody felt.
Iron restricted erythropoiesis as such, this is more common in advanced stages of bulimia than compared to the earlier stages.
So do you think it will, are you in the habit of using hybrid, both desidustat and EPO?
No.
Right, okay. So there's no evidence for that. Ram is somebody who strictly follows evidences. I know him for many years now. The other thing is, anywhere in the dialysis population you felt that ESA did not work and desidustat did?
So in the single digit patients, so whenever we say wait maximum for 3 months, a group which doesn't show any improvement with 3 months, we make an attempt to change. But as I mentioned, most of the time they need higher doses than a lower dose. So
Right.
many times dialysis people will need 150 milligram, not 75 or 100.
So do you think it will replace erythropoietin in the dialysis population?
So I personally feel definitely there is a scope of this molecule. In dialysis, again, it is very difficult to say because anyway they are coming there, they will not get worried about poking. But what about in pre-dialysis patients? Definitely it has a big role to play.
Right.
And the adverse effects, as usual, I think with any new molecule, we are always worried about adverse effects.
Okay.
I don't think we have seen that many cardiac events, strokes, vascular acid thrombosis, malignancies. Though it is too early to say, I don't think that much is there because there are so many confounding variables in all these.
Right. And the other thing is you don't reach that sort of a hematocrit.
Rise. Yeah.
Right.
Again, percentage of rise matters more than the molecule or the mechanism of action.
Okay. So finally, in the lighter vein, how did that poor farmer reach SIMS?
He has come only as an outpatient. Had you seen the inpatient facility?
Farmers are not poor. Government pays all the taxes.
The farmers from Kanchipuram
They are
are landlords. I have actually
Poor
known
tax
one
is
of my
poor.
close
They are
friends
actually
who was on a home hemodialysis. We have maintained him for home hemodialysis for close to 4 years. He was a farmer who wears a dhoti and comes there.
nowadays we can't judge the
I think
place.
Sivappa was there.
Correct.
That time our home hemodialysis fellow was there. Almost 4 years we have maintained.
Right.
Unfortunately, not in the appearance, sir.
Not in the
True, true.
landlords, big land.
So thank you, Ram. Now I'll call Sujit to present his.
Good evening. I'd like to thank my godfather, Dr. Edwin sir, to
I am not your godfather.
I consider so most of the private practitioners, they don't me. They don't me. I am now working as associate professor in Stanley Medical College. And my only TRB is working as learning in nephrology under Edwin sir for 11 years. I am blessed actually. So coming to the topic, I will rush because it's getting near to the lunch, dinner.
Yeah. We have to adhere to timing.
So this is to that in the management of CKD anemia and patient adherence. So patient profile is 62-year-old male on maintenance hemodialysis for end-stage CKD on ESA therapy with suboptimal control. He also has hypertension and type 2 diabetes. Chief complaint was persistent fatigue, shortness of breath on exertion, and pallor for 3 months. He presented with progressive fatigue over months with hemoglobin stable at 9 grams on erythropoietin stimulating agents and limiting daily activities. He missed several sessions of dialysis due to fatigue and injection related discomfort, leading to poor adherence, that is compliance is less than 70%. The symptoms include dizziness and reduced exercise tolerance. So medical history, he had hypertension for 15 years, diabetes for 10 years, and CKD 3 years on maintenance dialysis. He had no malignancy, GA bleed or autoimmune disease, no recent infections, surgeries or transfusion in the prior month. He had years of hyperresponsiveness and secondary years of failure. His current medication include ESA injections, amlodipine for blood pressure, and oral antihypertensive discontinued because of euglycemic state now. His phosphate binder was calcium acetate. So vitals is 146 and 86, heart rate is 82, and BMI is less than 25 kg per meter square. Findings are he is pale, mild edema, low limbs. So cardiac status is okay, no signs of infection or bleeding tendency. So baseline investigation, hemoglobin was 9 and ferritin was less than 600, TSAT was less than 22, CRP is less than 10, serum iron is less than 60, reticulocyte is 0.2, serum phosphate is less than 6.5, and serum potassium is almost normal, and CRP is less than 10, and hematocrit is less than 28. So diagnosed here, our patient is a dialysis patient with anemia with poor ECA response or adherence. So desidustat was initiated at 100 milligram once a daily with a titration based on hemoglobin response. So this is, as we all know, it's an oral HF propyl hydroxylase inhibitor, stimulates endogenous erythropoietin production, improving iron mobilization and hemoglobin without the injections, so ensuring adherence over parent. He had good compliance. So after starting this drug, the anemia was almost corrected. The hemoglobin rose from 9 to 10.5 over 10 months period. So almost target hemoglobin was about achieved, and serum ferritin was 500. So it implies adequate iron stores. TSAT is less than 30. So improved iron mobilization. Serum iron is 90. So functional iron availability was there. Reticulocyte has improved. It confirms the erythropoietin response. Serum phosphate is less than 5.5. So there is a dialysis adequacy was good. And serum phosphate is normal, serum potassium is normal, so there is a safety for this patient. CRP is less than 5, so there is a reduced inflammation. Hematocrit shows improvement, it is less than 34. So follow-up of 12 months of using this drug, there is a stable hemoglobin with good tolerability. The insight is oral desidustat offers superior adherence in CKD anemia versus injectables, with significant hemoglobin gains and safety in real-world settings, especially post-EPO failure or PRCA. It has a superior profile to ESA in cytokine modulation, and it is well tolerated orally. Long-term data confirms cardiovascular safety with anti-inflammatory drugs. For any drug to be successful, it should be more patient-friendly, and patients should be more adherent to using the drugs. So this drug scores in this area very well. So these are the references. Thank you, sir.
So thank you, Sujit. So you feel that because of the oral nature of the drug, the compliance was better. That's what you're trying to drive at. Okay. Any other comments from others?
Not regarding this, I have a common question. Like, what about for AKD patients? Like somebody who's in between that phase. Like,
Right.
what do we choose for them? Like, do we wait?
There's no obviously study on that,
Okay.
but we assume that an AKD is actually going to land up with a CKD, because an AKI that generally recovers in about 3 to 4 weeks maximum. And again, you have to type the anemia. Very important to type the anemia, and if you are able to type the anemia, fine. There's one more index called the percentage of hypochromic microcytic cells. and the reticulocyte hemoglobin content. Both this are not found routinely in many of the CBC autoanalyzers. They have to be done separately, and that's why that will give us a better idea of the type of anemia. The reticulocyte hemoglobin content is supposed to be one of the best markers of iron stores, but that's not routinely available. Even the percentage of hypochromic microcytic anemia, I think it has to follow some standards of counting that percentage of hypochromic microcytic cells. So that way, I think more than anything, the type of anemia is important. Though we don't have any studies to support, I don't think it's a bad idea to give. Should be fine.
Actually, during the recovery phase of AK, madam, for tubular regeneration, some of the factors are needed, like hepatocyte growth factor, erythropoietin, and the BMP7.
Right.
If these molecules are there in adequate quantity, the tubules will regenerate on its own. The AK will recover actually. If the reverse happens, epithelial mesenchymal will transition. So there is problem to CKD. But some anecdotal reports actually suggested erythropoietin injection, higher dosage, 10,000 units, to improve the recovery actually.
Yeah,
tubular regeneration.
that's in very, very.
Not related to anemia.
Supposed to reduce inflammatory markers, no? So should it be preferred?
That's why I said you must give it for the right indication. Provided if you have a normostatic normochromic anemia, and if you feel that the cause of anemia is nothing but the CKD, the AKD, then I don't think it's a bad idea.
And regarding malignancy also, sir, is there, it's a broad term, is there any particular, what about for multiple myeloma and all, what do we do for such cases?
Talk about mostly the myeloproliferative disorders more than anything else. Myeloma, of course, I don't think that should be a contraindication.
I have seen the medical oncologist prescribing 200 microgram of darubicin.
I know.
10,000, 20,000
Yeah,
and
yes,
for the
yes.
myeloma.
Very high dose.
That's only malignancy I've seen this basically.
Can we
Especially
prefer
after
this
starting
in such patients? We don't know.
Again, we don't have any studies on such high doses of darbepoetin or erythropoietin in any of our population. And I'm not sure why they are using that high dose. I probably must discuss with them to find out what is their idea of using such high doses.
Generally, sir, to avoid chemotherapy-induced bone marrow suppression, they are using high doses. So
Yeah.
this is what they told actually when I was discussing.
I asked once, they told me that since their, prognosis is usually, the duration of lifespan, they are expecting
Shorter.
less shorter,
Shorter.
so they are not concerned about the high doses. That's what they told me. The long term, they don't expect.
No, again, if you look at the anemia of malignancy, there are too many factors operating. I'm not really sure that it is just a normocytic normochromic anemia. What if it is a chemotherapy-induced anemia, and if your kidney is normal, would this going to work? It will be landing up with more complications rather than anything else. So,
Sometimes this hypoproliferative anemia, whatever dose you are going to give is not good. They will keep for their own satisfaction. That's something they are trying.
Correct.
I don't think it has any big science.
correct.
We are desperate. That's all.
Whether this one helps you basically because reduces the fibrosis. That's what in the DMND you look at the reduces. So maybe AKI.
Theoretically, you can claim so many things.
No, as Vasu was mentioning, there were some studies that showed very high doses of erythropoietin even in ischemic AKI. But that is not really translated to clinical use. But there are definitely some papers on this. So we'll call Shiva to make the last presentation. Yeah.
Yes, sir.
Good.
Yeah.
Good evening, sir. Good evening, everybody. So, fortunately, I don't have seen a patient of usual nature epilepsy so far. Anyone of you have experience?
Yeah.
Yeah. Proven by the antibody?
Yes,
Yeah.
proven by the antibody. And
So,
he needed cyclophosphamide also.
how was the response then?
He was off erythropoietin, didn't take, after 1 year we re-challenged him with erythropoietin. This was more than 5 years back.
And it
Before the
worked.
one thing, he was doing it.
No.
So, this is I took this case from one of the case series.
Okay.
Rituximab. I was wondering. Okay. The patient was given rituximab, not the cyclophosphamide.
Cyclophosphamide is also approved for
PRC.
Yes.
So it's a 60-year-old gentleman. He came with a case of stage 4 CKD due to diabetic CKD stage 4. He's on EPO for anemia for the past 14 months. He comes with progressive fatigue. There's a gradual decline in hemoglobin from 10.2 to 6.4 in over 2.5 months despite EPO. He's recording 2 units per month for the last 2 months. There is no bleeding, hemolysis or iron deficiency. The medical background, as I told, is hypertensive, diabetic, CKD stage 4 on EPO. Baseline medication, EPO and BP drugs is on folic acid and IVIN. The hemoglobin is 6.4, the reticulocyte is reduced, the ferritin is in the range, and the peripheral smear is showing severe normochromic normocytic anemia, and there is reduced RBC production with other lineages normal in bone marrow. So diagnosis is antibodies was not done in that study, and only except for one patient, it was a study including 4 patients. Only one patient the antibody had done. So immediately EPO stopped, and they had tried with different immunosuppressions like cyclosteroids, CNA or cyclophosphamide, and all of them required transfusion. And 14 patients, of the 14 patients, all of them are started on desidustat. I'm just quoting one case. And the rationale, because it stimulates endogenous production, and there is no anti-EPO antibody formation. And this patient, hemoglobin improved from 6.4 to 12.5, and everything improved. Ignored the ferritin levels. So ESA-induced PRCA is a rare but serious complication caused by neutralizing anti-EPO antibodies, characterized by severe reticulocytopenia, transfusion dependency, and management requires ESA withdrawal and immunosuppression. And HIF-PH inhibitors like desidustat provide an alternative pathway, they promote controlled endogenous EPO synthesis, improve ionability, and we can avoid recombinant rechallenge with EPO. Same thing, sir. And up to date was also talking about using regulated EPO for
the long acting.
Sera.
Actually, this is the ideal indication for Pegnisalid hematitis.
Previously.
It was a mimetic agent.
But it didn't. It was even given in KD. That's it.
Thank you, Shiva. So I thank all the presenters. So we have come to a reasonable conclusion that this is a molecule that's going to stay with us. Probably Sun Pharma should take it up to study do a post-marketing work. Right now we are in a phase 4 trial at Stanley with desidustat by the Zydus company. We are shortly publishing the results. Probably we must look into the response in glomerular disease and interstitial disease. Is there any difference? And probably also look at the hybrid form of therapy, whether it could be cofactored along with the regular erythropoietin or darbepoietin. So these are areas I think we could look into. And as I always tell, most of our CKD patients are on multiple drugs. So the costing also, as of now we have kept the costing reasonable, but making it more affordable will definitely increase the use by doctors. And another thing is, please don't market this drug to general practitioners, gynecologists, obstetricians. Erythropoietin is used right, left and center for some Somebody's got hypotensive shock and anemia. I've seen it being used. So please have some meaning in some protocols in to whom you are marketing this drug. So erythropoietin has been used and misused, and after the generics came, when it became very less expensive, then you started promoting it to everyone around. So that means the drug will be misused. Right. I've seen patients with pregnancy anemia being treated with erythropoietin and having preeclampsia and the blood pressure shooting up. Right. So this is a request from all of us in the nephrology community that it should be used in the proper way. 95% of nephrologists are generally very academic and try to follow guidelines and do sensible practice and practical ones also. So I request you to take into consideration these things. Okay.
Yeah, sure. Thank you,
sir. So with this few, I want to thank Sun Pharma for organizing this and to thank all of you individually for being present here on a Friday evening, and to all the presenters who have taken extra efforts to make their presentations. Thank you.
Yeah. So thank you, sir, for sharing your expert insight and sharing your feedback and suggestion for the Sun Pharma. So definitely we will work on the suggestion in order to improve the patient outcome in the anemia of CKD patient. So thank you all the doctors for giving your valuable time for the today's meeting, and thank you Dr. Appanandu sir for moderating the meeting. And I think with this we conclude the meeting on positive note. Thank you. Good night. I think dinner is ready. Yeah.
Melbourne, Elizabeth.
Systematically studied. Today we should